Okay, I am now started recording. All right, everybody. So this is the agenda for today. I just wanted to bring up the SUDISA web page just real quick because I always bring up the SharePoint page. And so just so everybody knows, it looks a little different now. There is no more time clock. The time clock has run out. So there's no more time clock when you go to the SharePoint page. This mandate will probably be removed too, or I'll change it, or something will go right here. But for right now, meeting materials. You'll see the mural button is now gone. However, it is not gone and lost forever. It's still under group ideas and murals and other documents. We have a roster up here, a meeting record recording, and SUDISA reports. And so group ideas, mural and such, you click on this and we get to the old mural. So if any of you want to look at it, it's right here in PDF and PNG. And then other documents and stuff that we'll be going over today. Next is so the update on SUDISA recommendations, just so everybody knows. And Sarah or Michelle, if you guys have an update further than what I know, but I'm pretty sure that as far as what I know is that the SUDISA recommendations are with LAA, Legislative Affairs. Is that correct?
I think so everybody at the healthcare authority who needed to review has completed their reviews, and I believe it's in the last stages of review with the governor's office prior to being submitted to the legislature.
Yes. Okay.
I
So that's where it's at.
Yeah, and I haven't received. I don't believe that I've received any notification that it's been submitted yet.
Okay. Gotcha. So that's where it is, everybody. So some people were kind of curious when we met. They wanted to know what was the update on SUDISA recommendations. So that's where we're at right now. And so I'm really happy to see how many people are here today. It's really awesome. Really happy to see that. And so today, what we went ahead and I went ahead and SUDISA recommendations. So these came from you guys from the mural. These were ones that were not voted on, or people didn't get like the no votes, or somebody voted on one or two, but they just didn't make it into the recommendations whatsoever, right? The problem was with the mural ones is that they were kind of just statements and not really fully written out, right? And so I want to zoom in just a little bit so everybody can read it just a little bit better. I know how it is. So these are desired outcomes not yet met. And so what I did was I wrote them into possible written goals. So you got to remember I was taking a statement that some people liked and we were going to vote on it, and then they didn't feel really too strongly about it, and I turned it into a possibly written goal from how I saw it. So I wanted to go over each of these with you guys and see if we need to rewrite the goal. And then I don't know if we'll do it in this meeting because we only have an hour, and I've already seen a couple people say they might need to leave at 1:30, which is fine. But if we do have time, it's like, what can we do? And maybe we might have a mural for this part, but some simple things we might be able to put over here is what we can do. And we can make a whiteboard or a mural and put it up. Yeah, go ahead, Elizabeth. I feel like you like going by Liz.
I like going by Beth, but my
Beth.
my full name is Elizabeth
But
Kelly.
Beth.
Never mind, just call me Miss Myers. Anyway, I'm teasing. Beth is fine, or Elizabeth. So I think that this statement was something that I was struggling with in the beginning because I've worked in different settings,
Hmm.
and I've been an SUDP for many years, and am very familiar with the ASAM criteria, and the dimensions and everything. And then I came to a medical setting, and there was all this confusion around the word assessment, and for me anyway. I mean, they have a completely different notion of what an assessment is, and it has different meanings for different people. And I wanted it to all be uniform. And what I know now is that the government is going to be implementing, disseminating the ASAM criteria into medical settings over the next couple of years, correct? All right, or at least beginning in 2026. And the new criteria, the ASAM-4 criteria, is going to be hopefully used to, across each continuum of care, so that it's people get what they need instead of, you know, in one place they get this, in one place they get that, you know, and they're not always successful when they leave because their goals haven't been met consistently throughout all their needs, you know, to address all their needs. Anyway, yeah, so I think that notion, I'm pretty sure it was something that I said, like primary care and a behavioral health. Yeah, because screenings and you know, the screenings are starting to be the same kind of screenings. They do mostly the SBIRT here in the medical setting for substance use. And they might use a different one in a behavioral health setting. But as far as assessments go, I think that we're addressing that.
Okay, I mean, I can also put that too. I'm not afraid to put down. This just got moved over to desired outcomes not yet met. We were that
Right.
last meeting with SUDISA went
I
pretty long.
understand. I understand. I'm just saying that I don't know if it's necessary to continue. Like my original idea, like the goal to have an understanding of screenings in every place is going to have a little bit of a different process currently for screenings, for example, or intakes, which is a whole nother thing. I mean, each one of these things is different separately because intakes can be really challenging for, you know, if you go into a treatment center for first you've got the courage to go up and ask for help, and then you have to sit down and read like 20 pieces read and sign 20 pieces of paper, or just sign them all and hope for the best, you know. And it's a very complicated process, just the intake. I think it should be simpler. um, and then assessments,
So Beth, what I was gonna do
I
is I
don't
can
know.
check in with our trainers and ask them, and also
Right,
I can check in with some people at the HCA and ask them how much the ASAM trainings are gonna be for use for medical doctors and stuff like that, and
they are.
disseminate it
it's
towards them.
it's all over the
Oh,
HCA
okay.
website.
Well, that,
It's,
yeah, I've seen that.
yeah,
I just didn't know if doctors were actually attending.
well, it's going to be disseminated in hopes
Yeah.
that everyone in the medical, you know, medical providers are on board with. It's my
Okay.
understanding. So I
All right.
thought
Well, if
that was
everybody,
wonderful news. It made me very happy. Like, I hope we all get to eventually speak the same language as far as substance use and assessments and recovery and so forth. But, you know, it's an ongoing thing, right?
no, very much so. I totally agree with you. I'm very happy to hear that you're saying, that the dissemination's going well and everything like that. So I'm super appreciative. So if everybody's okay with it, unless there's somebody else wants to speak more to number one, we can go down to number two. Is there anybody that wants to speak on number one?
I was just saying we could eliminate it.
Okay. Is there anybody that has an issue with eliminating number one? I do have this saved somewhere else, so it's not really being eliminated. And then also too, I'm going to
Okay.
do track changes, so it will mark it out, but it's going to be able to be readable if we want to.
Yeah,
I'll
and
just do
then
that.
the 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 goal that you set is kind of different, you know. I kind of like the idea of, you know, separating each one. Like, let's figure out what the screening process is across the board, and then let's figure out the intake process across the board. You know what I mean? And the assessment process. It's probably, you know, that's too much to even ask for. But it's the assessments that should be uniform because those follow people you know, they could follow and they could get their needs met if everybody knows their problems and their goals, right?
Yeah, and
Although
so,
the
oh, go
new
ahead.
assessment is different. Anyway.
Well, no, I was just going to say number three. We're about when we get to number three. I think that really goes along with what you were saying, though.
Okay, yeah, so let's
Uh,
just erase number one. I mean,
yeah, I'll mark.
uh,
I put down
unless you
mark
want
out.
it, you can
No,
have it.
I put marked out. Is there anybody else that feels like number one should stay, or is it okay with me marking it out? All right. So for right now, I have it marked out. So I'll go back at the end of this, and anything that says marked out, we'll be marking it out, and it'll be deleted from this table, but it'll belong to a different table, so that we don't lose the information.
Cool.
Make sure.
Thanks.
Oh, yeah, no problem, Beth. Thank you for the comment. I super appreciate it. Make sure we have the facilities a rollout for them to understand and implement new policies and required timeframes. What I translated that into to ensure that all facilities are equipped and prepared to understand and implement new policies within the required timeframe, facilitating a smooth transition and compliance. I guess if anybody knows who put this on the mural, I'm guessing when I got this, I basically was saying like, well, I'm guessing that a lot of people feel like when stuff is rolled out from government agencies or like the ASAM, there isn't a smooth transition, and so that's what I read into it. So if there's anybody else that reads something different, I'd be more than happy. Or it just like Beth just mentioned, if for some reason this is not cohesive enough for us to do something with, or we don't feel like there's a goal really established, we can mark it out as well, because our goal is not to just be going over things that we're trying to figure out. The goal is to get some goals on the page and then figure out what we can do with those goals. So I'm just curious if anybody wants this rewritten, or if they want it marked out. If I could hear from a couple people, that'd be greatly appreciated.
And Kelly, maybe it would be helpful to explain a little bit more. I know you talked in the beginning, like the 4 core recommendations that made it into the report, obviously are recommendations for the legislature to hopefully adopt or consider adopting. And then sort of what, with these remaining ideas and goals, like how we will, if we keep them on, how we'll continue to like work towards understanding avenues towards like having these adopted, or maybe if the group understood the scope of influence outside of the legislative report, that might be helpful context as well.
Yes, and I wouldn't mind some of your help on this, Sarah, because as I remember it, it's there is things like we can do decision packages, right, to help move this along. And I'm trying to think of other ways. I know we discussed it once. Do you have some ideas about how it could get moved forward
Yeah,
if
I mean,
these got
yeah,
recommended?
basically, so the healthcare authority being like an executive branch of government, like we, can only put into place what's enacted by law, and we work through the governor's office. However, like if there are still priorities of this work group that can be uplifted by the healthcare authority through, as Kelly mentioned, decision packages, which are essentially a request for additional or supplemental funding for initiatives that would require funding, or agency request legislation, which is essentially like amending state law to adopt some things, or even just things that are maybe already in our wheelhouse and kind of in our book of work at the healthcare authority that we can continue to put forth as recommendations. Or we can put forth through existing resources. We just didn't necessarily want the momentum of the group to end with the few recommendations that we had time to like put forth in sort of a condensed time period, and still want to ensure that if there are additional priorities that weren't captured within those 4 core recommendations, that we're continuing to consider like ways to either advance those through existing resources, or look at other avenues to advance them. Hopefully that makes some sense.
Sir, even you saying that kind of did give me an idea, and I wanted to give it to the group real quick. Like, for instance, facilities do runs over it. That kind of goes towards a DOH kind of thing. And so, if we're hearing anything from any person in particular group that they feel like a policy isn't implemented, if they need help with policies and stuff, maybe there's a way we can give them contact information at DOH facilities. But is there anybody in this group that might have written this that had issues when certain things were rolling out that were law that you didn't feel like was rolling out quite well, and you could have used extra support around that? Well, I'm gonna move on to the next one for right now, and I only say that oh, go ahead, Alicia.
If I'm remembering correctly, I think this was just about the Suboxone and who could prescribe, and just making sure that people were aware of the changes as they were happening. But for some reason, I just think that it was surrounding prescribing Suboxone.
You're talking about you're talking about requirements of like residential facilities are required now to take Suboxone and methadone and stuff like that.
No, I'm talking
Oh,
about there was a change in who could prescribe Suboxone, and not
oh, okay.
everybody knew that it's much more open than it used to be, that the doctors didn't have to take that certain so many hours of training. And I could be wrong, but that's how I remember number two is that not everybody knew about those changes.
Oh,
And
like the
so they were,
removal of the waiver.
yep, that's it.
Oh, okay. That's actually addressed in one of the recommendations.
Yeah.
Um,
And so I don't remember anything else specifically about this, but that's just what triggered my memory when you were talking about it.
okay.
So one of the recommendations did have to do with like an educational campaign for some of those, yeah, like potentially like statewide or even like national
Right.
changes that might require additional education, like the removal of the X waiver, and also just broadening within the state plan amendment, like who can do a substance use disorder clinical assessment. So like some things like that. But I feel to me this recommendation seems to also encompass something that maybe wasn't captured in that recommendation that was put forth to the legislature in terms of just providing like dedicated training and technical assistance for any like major new laws or policies like that are going to impact substance use providers and the way that they provide services. So maybe that's covered, but I think our recommendation that we had, like the recommendation that was written into the report, had more to do with like launching an educational campaign rather than some of that like dedicated um, technical assistance and support in rolling out new policies. That's where I'm seeing, maybe some difference between what we recommended and what, or, what was written into the report and what we have here on the table.
Yeah. So is there anybody that wants to keep this, that wants to look into this, that thinks this should be a goal? Because there's some good ones in here. We started off with these two because they're the first two I copied and pasted. So, um, is everybody okay with me moving on to the next one?
Well, Kelly, maybe it'd be helpful to
Okay.
give a real quick before we move on, like I know we talked about like the no wrong door policy, which I'm now blanking on the legislation that was passed, I think in 2021 that required.
2642.
Thank you. Yes.
Yeah.
Yeah. So I know that like there were some learning curves involved with that as far as like inpatient facilities accepting folks who might not have had an outpatient provider complete a full ASAM assessment prior. So that's just like maybe an example of this in practice. Um, that might be
Okay.
helpful.
And no, no. That actually is. I give some practical example right here. So right now I have the goal right here to ensure that all facilities are equipped and prepared to
Mhm.
understand, implement new policies within the required time frame. So like for instance with 2642, I just want to make a note to that 2642 and how we get the information out. And then I want to look into that. And does 2642 belong to us or the DOH? Does anybody know? Eliza?
So what
Maybe? Oh,
information
right
are
there.
you thinking of? So what information are you thinking of, Kelly?
Probably the billing aspect is what I was thinking of. The 7 days,
So I
right? That's the new thing.
No, so
Oh, okay.
2642, that information, I was a part of that implementation team back in
Hmm.
2021. And so that information was pretty well disseminated. We had a whole provider listening sessions, MCO listening sessions to help understand that there was no prior authorization required and the elements around the two business days for inpatient and residential, and then the 3 calendar days for withdrawal management. As far as the 6228 legislation, that's going to be requiring after those minimum requirement days of the 2 days for residential and inpatient.
For residential and inpatient, it's going to require no less than 14 days for initial authorization. And then for reauthorization, 7 days. So that's the first step for us as HCA that's implementing those requirements. DOH is not a part of that, um, at least as far as implementation goes, because it has to do with the payers, right? That it lands on. So it's OIC, it's us at HCA, and it's the MCOs. So it's going into MCO contracting and whatnot that's what needs to happen. The piece that providers had voice in when it came to 6228 is that there was work groups, there was gov deliveries that went out, and there was work groups that there was discussion about um, how the uniform authorization process was going to take place, because that was a requirement in Section 9 of 6228, because there's been a push to look at, how we can make this a more seamless process with different MCOs and carriers asking for different things and then needing different things, and it delaying the process. And so the work group did come together, and recommendations are being submitted to the legislator that came from that work group. So there's going to be more information that's going to be published regarding that outcome. And so that's looking at more uniform processes for authorization overall. So there's a lot that's happening on that front as far as making the process easier and having those standardized requirements. And those standardized requirements are already codified. So they're already in law as of January 1st.
Okay, so I mean, like, I'll echo what Sarah said in the chat. So maybe we've already got this part dialed in as far as facilities. But if someone in the group has, they belong to a facility, or they've heard of something where they don't feel like information is being disseminated to a facility on rules or laws or policy and procedures that should be at facilities and stuff, you can go ahead and email me, and I can look more into it for you, and I can come back to this as well.
Kelly, what I would really encourage is that, because our BHA is contract with MCOs, in addition to that, emailing Kelly is a great option. I would also really encourage that you email directly with your MCO partners. They are really supposed to be ensuring that you all understand the expectations, because if they're tasked with it, they're likely tasking you all with it, right? So, and you all have the contracts directly with them. So it's going to be important that that line of communication comes directly from your MCOs who oversee your contracts.
Thank you, Eliza. I appreciate that. Yeah, so I mean, you also have your MCOs that you can contact, and or me, and whichever one. I appreciate you echoing that, Eliza. Thank you so much.
Mhm.
All right, so I'm gonna move on to the next one. So I think this one is a really good one. Honestly, I have to speak just from like the ones I've written down. I think it's a one that I'm surprised we didn't try to figure out in the final recommendations, but one issue with assessments are that treatment centers can sometimes not accept the assessment already conducted by another agency organization. Someone had put incentives to do them themselves because assessments are billable. That's what someone wrote. I didn't write that, so just make sure. But I wrote the goal is to address the challenge of treatment centers not accepting assessments conducted by other agencies by establishing standardized assessment protocols and promoting collaboration among organizations, thereby reducing redundancy and enhancing continuing of care and the transition from one substance use disorder treatment, SUD, to another substance use disorder treatment. So basically, right now, as you guys know, there's some agencies that will accept an SUD assessment from another agency. They'll use that assessment. They'll put in an extra page if they have to, or something like that, and then they'll take that assessment and they'll write on it or whatever, and then they'll put the personal level care, and then that's what they'll do. And then some agencies are like, nope, we do our own assessment because that's too difficult or whatever. And so I would really like to hear from some people on this, because I feel like this is actually a thing that does cause problems sometimes, because you want to get someone in real quick, but they got to go to that first assessment appointment. It's a couple hours long right now. Though the ACM4 is going to come out with something new, and we don't know how that all is going to come together right this second. But I'm really curious to hear from anybody if they want to rewrite this goal in a different way. I can even take little sentences if you were to put them in the chat, and we're like, oh, I would really like it if this goal did this, you know, and it doesn't mean that's what's going to happen, right? But we can at least write it down, and we can do that. So either like how it should be reworded or what we can do with it, you know, like what would we like to see happen? I was thinking more like a toolkit, maybe. Maybe if we had a toolkit for people, for agencies, like this is how you accept someone else's assessment. I don't know who created the toolkit yet. I'm just saying that's an idea. Thank you, Dr. Khan. Is there anybody here that has issues that wish their policy allowed them to take other people's assessments? Go ahead, Alicia.
I think it's actually a bigger issue than than it may need to be or want to be, just because of accreditations and we have certain requirements that the state requires us to give us, and then certain information that the MCOs need to have. Certain requirements, like if you're CARF accredited or other type of accreditations, that it's not about not accepting other from my perspective, it's not always about not accepting other assessments. It's about other information still needs to be gathered in order to meet the requirements. So that's why a new assessment oftentimes now is done. I'm not saying that there aren't others out there who do it because they can bill for it, but I really think it's a much bigger issue of data than just not accepting them.
No, for sure. I used to work at CMAR. They're JACO accredited, and if I got an assessment from someone that's not JACO accredited, it would have been very hard to do their SG assessment. Um, because JACO requires a lot more information than your standardized assessment. And so I wonder if there could be a toolkit created for people that are coming from a JACO facility to a non-JACO, well, I mean a non-JACO facility to a JACO, or CARF, non-CARF to a CARF, where the the questions could be added and stuff, or some way, you know what I mean? I'm trying to figure it out in my brain right now this second, but no, Alicia, I appreciate that. That is a problem, right? How would we bypass that issue with this goal? If we wanted to make it standardized more, how could we do that, you know? And so I think talking about the problems right here is a good place to start. Is there anybody else that wants to say something on this? What would be other issues with trying to implement standardized assessments across, not standardized, but trying to make it so that other facilities can accept other facilities assessments? Is there any solutions where somebody might have an idea where how we could make it so that facilities could accept other facilities? Like, is there a gathering that could happen? I'm just curious.
This is Eliza. I think one of the things that I think is also going to be helping with this is again 6228,
Hmm.
because again there's been a push, like HCA has to have a standardized tool, OIC has to have an adopted standardized tool, and what's been that adopted tool that's now being put into law is going to be the ASAM tool, right? And so with utilizing ASAM, that level of care assessment and then that treatment plan assessment is what ASAM tool implements, right? So those elements is going to be expected. And then if there's a standardized expectation of, a form or a process, then hopefully that'll help.
Okay,
And
thank
this
you, Eliza.
came and this came from provider voice. Like this came from before this bill was put into play. There was a lot of meetings, with Representative Davis and others where we heard a lot of provider voice, a lot of yeah, I think this has come up in a lot of great forums like AAP and all of those places. So a lot of provider voice went into that.
Yeah, thank you, Eliza. I went ahead and put it on there because maybe there's some way we can, I can track this on my table so that I can let other people know, even in this group, like whenever this is happening and how it's all going down. So I appreciate your comment.
Mhm.
I'm gonna move on to the next one. If anybody wants to say anything else on this one. Okay. Someone have put mobile intake services should be more accessible and available to individuals who cannot leave their home. To enhance the accessibility and availability of mobile intake services for individuals who are unable to leave their homes, ensuring that all clients receive timely and effective support. How does, when I'm looking at this and I translate it into this, is there anything else anybody wants to add to this? Like I can put a comment or a bullet point or anything or anything that someone said. Does anybody have any ideas on what we could do? How this could be accomplished? Like more contracts? I can always come back to this, but I'm just curious. Something for everybody to think about. The next one is smoother transition from ED to inpatient or detox. This was not on the mural, actually. This came at the very end of our last meeting. We had someone speak up about this, and so I added it to this one. And I put facilitate a smoother transition from emergency department to inpatient or detox services, ensuring timely and effective patient handoff and continuity of care. Is there anything anybody would like to add to this?
I have a quick question rather on this one.
Yeah.
So what is the current standard of care? Because I hear few different things, especially when it comes to transitioning from emergency room. So what is currently being done? Do we know?
Yeah, I'll speak on this a little bit, and if there's someone in the room that if I okay, there we go. Angela, go ahead. Oh, Angela, you might be on mute. Angela, we can't hear you. Um,
The reason I ask is mainly my questions, I think, around the detox facilities, because we don't have a lot of detox facilities, at least when I speak about Pierce County. So I'm just curious to see if anyone has some more insight into this.
I can say a little bit.
yeah. Angela, are you there? Oh, she said she added this to the comments, but I'm not sure this group can help. I think it's a good discussion to have. Beth, thank you, Angela.
I was expecting that. I'm not even gonna lie. Yeah, okay, handle it. It's okay.
Hello?
I thought someone else was talking, but what I've noticed is I only work 8 hours, 5 days a week. And so when I'm not around, sometimes it's a challenge. There is a process to do it, but sometimes detox facilities also do not take a lot of times complicated medical. They don't have the capacity. And I know that in one of the upcoming changes, hopefully they will, the detox centers are going to be having more people, more medical capable people to provide services to those even that are struggling with other complicated, serious medical conditions. Like, so sometimes somebody wants to go and the detox facilities cannot take them because of various reasons. So that can be a challenge. And yeah.
Yeah, and I'm just speaking on my own experience here when I've had ERs that wanted to bring people when I worked at CMAR and stuff. We had, and I was really trying to I usually was an accommodating provider, usually. But like medical stuff, a lot of times someone's on oxygen, that could be a barrier for someone getting it. Sometimes it's 2 a.m. The person's supposed to discharge. I couldn't take someone at 2 a.m. And I was residential, I wasn't even detox. So sometimes the ER would actually have them for a few days where they were detoxed enough where I could take them. But if they want to discharge them at 2 o'clock in the morning, I couldn't take them. So I mean, yeah, and Angela, you're right. Each detox has their own requirements. Sometimes those seem to change day to day. It depends on who you talk to and stuff. And I wish there was a more standardized way between residential detox and the ER. Beth?
Yeah, and another issue is older people. And so a lot of skilled nursing facilities do not take people with alcohol use disorder, but they also don't have an option for treatment, inpatient treatment sometimes because of their medical conditions. So it can just be really challenging for people that are really ill and have a desire or want to get sober, and yeah, and yeah, it's agreed. Each detox has their own requirements and depends on who's interpreting those requirements on what day. So it can be a challenge. It would be nice if there were options for older folks. I have had good luck with one facility currently. They still needed to be able to. They have to be able to, take care of themselves. They have to be able to participate with withdrawal management, and if they want to do inpatient, they have to be able to do the programming. So sometimes there's people that are not healthy enough to go to rehab, and
No,
and the nursing homes don't want them either. So it's really challenging.
yeah, no, and I put that on there. Skilled nursing homes does not take people with SUD basically. So they don't take people. A skilled nursing home, if someone just got done detoxing, a skilled nursing home won't take someone with alcohol use disorder then.
Often they won't.
Often.
Sometimes they
Okay.
will. Sometimes they will if the person has been sober. There's evidence that they've been sober, and that it's, it just depends. But usually they will not take someone who's actively like going through withdrawal and even if they've gone through the withdrawal in the hospital, it's still hard to place them in a facility. So,
Thank you, Beth.
yeah.
Hey, Angela, did you join by phone by any chance? I just saw someone join by phone.
Yeah, that's me. Thank you.
Okay, that's what I thought.
Yeah, no, I agree with a lot of what Beth just said, and it does seem like Harborview specifically, we have so many people from our community seeking detox on a daily basis, and it just, we have relationships with certain detox facilities, and there's been such a huge issue with staffing ever since the pandemic. I mean, pre-pandemic, it was quite a smooth process to refer people to detox, and then ideally they would be connected with inpatient treatment from there. And since the pandemic, it's just been a struggle to connect people to any sort of treatment. Besides just like a next day appointment to get one of those SUD assessments for treatment. But when someone is in the ER needing help in that moment, it's just been really disheartening to send them away with a piece of paper. And I'm not sure the scope of this group and how we can help. We had many detox facilities closed down during the pandemic completely, so we lost those detox beds, and yeah, that was one of my core issues when we started this group, and knowing that we had other focus throughout the year, but that's always kind of been the thing that we struggle with, one of our top struggles in the ER.
Thank you, Angela. Beth?
Yeah, I was just gonna give an example of a patient who was seeking withdrawal management. She was seeking detox, and she was not in withdrawal enough and kept getting discharged from like 4 different emergency rooms before she was finally picked up and given services. So I don't know what the cost of that was, but I imagine it, it was a really challenging, like it's a lot of money, 4 different ERs before she finally was able to get into a program. Yeah, just wanted to mention that. And, I have a gentleman now who had to go to ER, 2-3 ERs before, and his health has to deteriorate enough to be admitted to the hospital from the ER in withdrawal. So there has to be life-threatening other than the alcohol withdrawal. And so it's challenging for the people and the people that are supporting them.
Curious, hearing from Angela and Beth, I just got a quick question. Do people ever attempt to go to the detox first, like try to walk in and then they show up to the ER, or is it always ER first, then they try to get into the detox to the ER? Anecdotal evidence, of course.
Angela, we do have one detox facility in the Seattle area that takes walk-ins, and I hear a mixed review of if they are actually able to get in or not. So it's hard to know. We can send people there, just they can try it on their own, but sometimes they're full. They don't answer their phone, so we don't know if they're full before we send someone down. So it's not a great system.
Just as a goal, I kind of just put need more walk-in detoxes. Does anybody disagree with that? I mean, like, I'm not saying we're going to make it happen in this group, but I think it's good to put down ideas. Does anybody see any issue with that we might need more walk-in detoxes?
Well, from what I'm aware of, so it just depends on the person, and the detox facilities always, in my experience, want to speak with the person. They do a phone screening. So whether they're in the ER or the doctor's office or at home 6 months after I gave them a list of facilities, and they find the list and they decide, oh, okay, it's time, and they call themselves. That happens a lot, and there's some places like, well, they don't take Medicaid or Medicare, but there's a couple places that will come pick you up now and bring you to their facility. So that's really nice, but it's not across the board for everybody, which, sometimes people need, we have, anyway, I'll stop there, but yeah, it depends on the person and the situation.
No, thank you, Beth. I appreciate that. Is there anybody else that would like to give more on this number 5? It can even be solutions if you think, well, could we do this? We can write it down. Doesn't mean it's going to get done, but we could write it down. Examine it. Dr. Khan, I saw your comment. Would you want to speak on that just a little bit more?
Yeah, hi. I feel like it is often not very clear when people say detox, and as a result, I think patients also do not quite understand, because detox is not like a one single problem that you could go in for and receive some XYZ treatment. Just like earlier it was said, it really depends upon the substance that's involved. It depends upon the person's commitment to what they want. Because a lot of times, like for instance, we do we're primarily we do medication assisted treatment, and we provide all kinds of medications, mainly for opioid use disorder. And it is so interesting that when sometimes folks come in and they come in with the mindset that, oh, I want XYZ medication and I just need help with going through withdrawals, and I plan to be on it for next 2 weeks, and then I'm going to wean myself off. So I think it's really important to understand that, going through withdrawals from an opioid use disorder is one thing, and then going through withdrawals from an alcohol use disorder is a completely different syndrome, which could sometimes be fatal if not addressed correctly. So that's why I think it's really important to understand what quote unquote detox means. I personally, in my practice, I am not a huge fan of this term, just because what it could mean to different people, especially when they're that vulnerable and sometimes desperate, to seek help. Because in the past, there's been I've had experience with some detox places where they would not allow any medication, and they would
Yeah.
just expect patients to show up with a clean UA, and that's, I think, really not practical. And I think it's a bit unfair to the patient also, to have that expectation from a facility. So I think we need to understand what, quote unquote detox could mean and use it carefully. I think that's really the point I'm trying to make.
No, Dr. Khan, I think that's great. I'm just thinking about, like, I'm a patient on the street. I'm homeless. I need somewhere to go. And of course, everybody hears the word emergency room, and that's the first place they think this is the place that's going to help me. And I wonder if there's something that we can create in this group where it'd be more like the mindset of, like, if you have this problem, these are the best solutions. Oh, okay,
Absolutely.
yeah.
Like, for instance, even for, like, from the state, and I don't want to take too much time. I know we're kind of pressed on time, but for opioid use disorder, if you like, we take walk-in appointments, and I can guarantee you, if your patient shows up, and if they're like within that window, they could actually completely bypass the need for a detox if they get medication on time.
And yeah, and that that goes towards making sure people know more about the opiate use disorder medications. And yeah, no, I agree. I think that yeah, no, I was just thinking, thank you so much, Dr. Khan. That brought us some good stuff,
Of course.
Yeah.
Of course.
Well, we got about like 2 minutes left, so I figured maybe I'll try to get this one in just real quick, because I think everybody's going to agree with it. And they're going to be like, yep, we should figure out a way to do this. Fee cap. Keep the fee cap longer than a year. To extend the fee cap on licensing costs for providers beyond 1 year, ensuring continued financial relief and support for service accessibility. What does everybody think about that? You can do the clapping emoji. You can be like, yeah, that's good. Does anybody know who the fee cap, does that belong to the DOH? Do you know, Eliza, off the top of your head? Sarah, do you know if the fee cap belongs to DOH?
I don't know, but I would assume.
That's what I think too. I'll find out more about the fee cap. Oh, go ahead, Elijah. I mean, Alicia,
Hear me?
sorry.
Can you hear me?
Yeah, we can, Eliza. Go ahead, Eliza.
Sorry,
Then we'll go to
I
you,
was
Alicia.
double muted. I was double muted.
Okay.
Yeah, it belongs to the Department of Health. The reason that the fee cap was put in place was to help bring more parity amongst like the different credentials, because SUDPs and SUDPTs notoriously had like way higher.
Yeah.
So I think the intention is to keep it longer, but I would definitely vote for it because I'm, as an LMHC and SUDP, I would like to keep my SUDP, but $100 is way better than like the 300. So I'm in vote of yes. So DOH would be who I would go to.
I will do that, and I'll get back to this group and see where we're at. Alicia? Thank you, Eliza.
I was just going to say, I would love to keep it lower. I just don't know how we're going to be able to fund that.
Yeah, the deficits are going to be, it would be interesting to see what DOH has to say about it because of the funding and like all the information coming out about some concerns about shortfalls and whatnot.
Okay, I can go back to DOH and ask them what the plan is and where does the funding come from, because it'd just be interesting to know. I'm also a license holder, so I would like to see the fee cap stay for, 10, 15 years, whatever. But I think that's all we have time for. We only have 2 minutes left, so I don't want to move on. I want to give each goal kind of. We only have like two. Well, I marked one off, so we have 2 left right now. So when we get back next week, we'll go ahead and be talking about the 2, and then talking about goals and such. And yeah, is there any last comments that anybody has for the group? Well, I just want to tell y'all, I appreciate each and every one of you being here. Thank you so much. Your time is very valuable. We are meeting, our next meeting will be February 17th, 2025 at 1:05. And yeah, no, I appreciate you guys being here. And yeah, thank you so much.